The following program on PBS 39 is made possible in part by
The Eye Center of Fort Wayne is devoted to eye care. Dr. Rex Parent, along with medical optometrists James French, Paul Gill, and Gregory Zink, specialize in medical and surgical eye care. For refractive treatment, the Eye Center of Fort Wayne utilizes technology such as Bausch & Lomb custom LASIK and multifocal refractive lens exchange. More information is available at 424-5656 or drparent.com.
And good evening. Thank you so much for watching Healthline Live here on PBS 39 HD. I'm Mark Evans, your host. Another very interesting program and interactive, hopefully. You call us with all the questions that you'd like to ask tonight regarding eye care. And we have our very special guest back at the Healthline desk, Dr. J. Rex Parent, ophthalmologist and eye surgeon in the Fort Wayne area for more than 25 years. It's great to have you back.
Thank you very much. Happy to be here.
Always a delight to have you. And then you brought along a guest who actually had cataract surgery not too long ago, May 24th to be exact, Susie Powley.
Yes.
Are you seeing things okay now?
I am.
For the most part, and then you
Pretty
have another
much.
surgery expected soon.
Yep.
But we're going to be talking to you more about that in depth as the program goes along. So sit tight and enjoy the show, okay?
Thank you.
The last time you were here with us, Dr. Parent, we started to talk about a couple other issues, glaucoma in particular, and we didn't have a whole lot of time, so I thought we'd pick up where we left off, and then we'll talk about the cataract surgery and the wonderful things you're doing with that. But glaucoma, as I was doing some research today, I found out that it's actually not one particular disease. Glaucoma is an umbrella for several eye disorders. So can you explain that a little further?
That's correct. The main thing with glaucoma is that it's a disease of the optic nerve, and in other words, it's a disease that damages the optic nerve. And when it damages the optic nerve, people lose side vision. And when they lose side vision, then they can't see peripherally, and they have difficulty seeing steps, other things like that. Now, this is laid on with glaucoma. But one thing that we used to say glaucoma is a disease where you have elevated pressure in the eye and that damages the optic nerve. Now we know that you can actually get damage to the optic nerve with normal pressures. That's normal tensive glaucoma. You can get damage to the optic nerve with heart disease where you aren't perfusing the nerve. And you can get damage to the nerve most frequently with elevated pressure in the eye. So when the eye pressure goes up, you can get damage to the optic nerve. I think if we can look at number 7, this actually shows on the left side, you'll see blood vessels extending out of a little orangish pink thing with a white area just to the right. That white area is called cupping of the nerve or scooping out of the nerve or damage to the nerve. And everybody has a small area like that, as pictured on the left in that particular picture. Now, if you look at the right, you'll see those same blood vessels, but you see how big that white area is. Now, that white area is very similar to taking an ice cream scoop and scooping out tissue out of the optic nerve, and that's from damage, either from poor perfusion or poor blood supply or high pressure in the eye.
All right. And of course, it affects 1 in 200 people aged 50 and younger and 1 in 10 over the age of 80. What does age have to do with this?
Well, in the edge, in fact, if we can look at 8, which has to do with open-angle glaucoma, fluid's made in the posterior portion of the eye and goes around that little tenuous thing that comes out, and that's called the iris. Everybody knows what the iris is. That's the colored part of your eye. Then it goes around the iris and goes out a sieve in your eye. And that sieve is called a trabeculum. And that sieve, as you age, several things deposit in that sieve. It's just like you had a sponge, and for 25, 30, 40, 60, 70 years, the material inside your eye tends to irrigate out through that same sponge. And when it irrigates out through that sponge, then the sponge is likely to clog up. And materials such as glycosaminoglycans, certain other materials, including pigmentation, can deposit in that sponge. And that can cause a problem with increased backflow into the eye or poor outflow of the eye. And therefore the pressure, your eye continually makes the same volume of aqueous fluid, it's called. And if you aren't able to push as much out, then your pressure in your eye will elevate and go up.
Well, a little physics there, and I understand that a little clearer. By the way, we have Mike on the phone, line 1. We'll get to him in just a second. I do want to remind our viewers, since it is an interactive program, Dr. Parent, we'd get their phone calls at 969-2720. That's the local number. Of course, long distance, we have many of our out-of-town friends watching PBS 39. It's 1-866-969-2720. Call anytime within the next 25 or 30 minutes, and we'll be more than happy to address your concern or any question that you have about eye care. Let's go to line 1 with Mike. Mike, thank you for calling and waiting on hold there for a couple of minutes. What is your question for Dr. Parent?
I just recently went to my eye doctor, and he gave me an exam. He said everything was good, and within a couple of days later, they called. Now they want me to come in for a re-exam, and I am diabetic, and they just said they just wanted to recheck some things. Now, does that sound normal?
Well, Mike, that sounds reasonable. The thing I'd say to you is, how long have you been diabetic, Mike?
About 5 years.
About 5 years. Usually within the first 5 years, very few people get diabetic retinopathy. But I'll show you what we're talking about. If we can refer to number 12, slide number 12, and I'll talk to you about that as we look at the slide. But in graphic number 12, on the left side is a normal, healthy retina. And if you look on the right side in the center, on the left side, just to the left of that, or just to the right of that nerve that we looked at before, it looks orange and normal in color. If you look on the right side, you'll see there's white stuff in there, and that's actually serum that leaks from your vessels, just like if you cut your hand, how your finger would ooze. So that's serum. And then if we can go to number 13, so things leak out of your vessels. They become somewhat impatent, and they can get leaking. And then with proliferative diabetic retinopathy, again, on the left is a healthy retina, and on the right is proliferative diabetic retinopathy. You can get abnormal blood vessels that form, and those blood vessels can sometimes actually bleed into the center of your eye. And when they bleed into the center of your eye, they can make you to have sudden decreased vision. And if we look at number 14, in number 14, if you look at these arrows, this is a patient where it's ordinarily orange in the eyes. We've seen in the last few. These arrows point to areas of treatment where we've used a laser to actually treat the eye or seal up these areas that are leaking. So those are the ways we treat diabetes. Also, we use a medication called Avastin, which many of the retinal specialists use, and the Avastin then decreases inflammation in your eye. So, Mike, what I'd tell you is, number one, I'd ask specifically what they're thinking about. I mean, it's your eye, so you need to know. It may very well be that they saw something on a test they ran, and they want to get you back and take a look at it. Certainly with any diabetic, you need to be vigilant about your eyes. Diabetes is one condition that can diminish your vision. So I'd say, Mike, what they've told you is reasonable, but certainly in your situation, I'd ask specifically what they found, and then if you feel there's a big concern, you could certainly talk to the doctor and even get a second opinion. There's never a problem with getting a second opinion.
All right. Mike, thank you very much for your call. We have Esther on line 2, and Esther, your question's about cataracts. I'm going to segue to that subject in just a couple more questions, so stay with us, okay? Don't go anywhere. Stay on the phone. We'll be right with you. I want to talk about the treatment success of glaucoma. Is that coming along? Are you satisfied with where it is right now?
Yes, actually, it's strange because many people with glaucoma, you have people with glaucoma, as we talked about, who have pressures that are just mildly up, and they show a lot of damage with glaucoma. You have people that have had pressures up for 20 years and never get damage from glaucoma. So, but the treatment itself, it usually starts with drops or a laser. A study was done that showed doing the laser has just as good a result as using drops, and using drops is just as good as a laser, and some people elect to do one or the other. The laser is relatively inexpensive, so the advantage of the laser is probably if it works well for you, you might buy several years without buying drops, and some drops cost $15 a bottle, some drops cost $70 a bottle. So those are things that you really need to discuss when you have the diagnosis made. But to make the diagnosis specifically, You need to have a patient, you need to ask about, look at their pressure, look at their side vision, do a special test where we look at that trabeculum or sieve where the fluid goes out of the eye. We're looking at the optic nerve. And you're asking about family history because some people say, yeah, my mom went blind at 56 years old. Well, that's a lot more urgent. You need to take care of that patient certainly much more urgently than you do. Somebody said, well, they said my dad had high pressures for 30 years and they never treated him. So all those things need to be factored in. But the treatment itself is usually drops or a laser. There are other treatments that we do if we do a combined operation where we do a glaucoma operation. Sometimes we take the cataract out and do a glaucoma operation. There's also a thing called endocyclophotocoagulation. It doesn't lower the pressure as much as a regular operation, but it's a pretty benign procedure, and if you can get a few points when you're operating on a patient, that's another thing we can do.
Very good. Very
good. A lot
of
options.
And I know glaucoma is named the silent thief of sight, since the loss of vision normally happens gradually over a long period of time, and often, as you mentioned, recognized when the disease is quite advanced. Do you see technology enhancing that? Maybe we can step it up a little bit and diagnose that a little sooner?
Yes, actually, diagnosis, we have optical coherence tomography and different things now to look at the optic nerve closer and to find earlier changes in the nerve. When we find earlier changes in the nerve, then we can diagnose it quicker. We can put the patient on medication. We can lower their pressure and reduce the risk for losing sight. So yes, I think that things are getting better. Another thing that we have some new glaucoma operations where they're actually small patent tubes that you put in an eye and allow a small area of the fluid to flow out, and therefore try to adjust the pressure with those.
And one final question from me about glaucoma: can it be prevented?
Honestly, no. There is no food. Some people feel that exercise, as with most things, may diminish your risk somewhat. People that exercise and stay thin, it may, but honestly, it's more an inherent thing inside your eye. And as I said, it's something that really people need to look at all those factors we talk about to make the diagnosis and then treat appropriately. You don't need to over-treat. Sometimes we'll treat a patient's one eye. If they're 80 years old and they have mild glaucoma, the chances are they'll still see, even if they weren't treated. So you have to make all those decisions with the patient. All
right. And if our viewers have any questions about glaucoma, please call us. But we're going to segue to cataracts right now. We have Esther on the line, and we're going to talk to Susie, who is a testimonial of cataract surgery. So many things to do on the program. But first, to establish what we're going to talk about, what is a cataract?
Well, again, we can go to our information that we have. And a cataract is a cloudy lens. Inside your eye is a lens, just like a lens in the camera.
And graphic number 1, there it is.
When the lens becomes cloudy, that's called a cataract. And the latest technique that I've done for years and years is to remove the cataract through a tiny incision around 3 millimeters or less, and we use an ultrasound machine. So with graphic 2, you can see that we take this machine and we actually go through a tiny incision. So if we can call up graphic 2, if we have it. Yes, there we go.
There we go.
And we use this tiny incision to break up the cataract with ultrasound. We suck it out through the inside of that small tip, and then we polish up the original lens capsule, which is kind of like a baggie or saran wrap. We put the new implant, which is 3, which is actually a lens. So we're taking a lens out, we have to replace it with a lens, so we put a new lens inside the eye, and there are different options for lenses too. And then number 4, the intraocular lens fits right back in where the original lens fit, where the cloudy lens fit, and again, the cloudy lens is a cataract. And when it fits in that position, we don't have to wear those thick old Coke bottle glasses, if you remember years and years ago. So they had to replace the lens with a big thick lens in the front of the eye. Now we put a lens right inside your eye. As far as we can tell, that lens is good indefinitely. They've done breakdown studies, and literally they don't seem to break down. They seem to outlast the human body.
Wow, and those, I see that it kind of has a hook on there so it doesn't float around, it actually stays stabilized.
That's right.
In the eyeball.
Yes, it fits right in the original lens tissue, and there are no vessels around that tissue. Therefore, you don't get autoimmune responses.
That is just amazing. I know we've talked about